So yeah, hi, I'm Tom Lawton. I'm an intensive care consultant in Bradford. I'm also the head of clinical artificial intelligence for NHS North East in Yorkshire. And I've been working with Ibrahim and other people here for some time. And most recently on the Shared Care project, which was funded by the MPS Foundation, to look at some of the aspects of legal liability, ethics, and sort of clinician preference when AI is used in consultations with patients. And I've got two co-conspirators, Dr. Vishal Sharma and Dr. Iacovides, to help present this with me, which we'll try and rush through. It's based on this paper, which I think has already been up on the board, but that's sort of my section we'll be going through. So we've recently installed an AI radiology system at Bradford, and this was the last paragraph of the email that was sent out describing its arrival, that essentially humans take responsibility. And the right-hand side is a common quote from AI vendors. Human oversight is important. And we, as the clinicians, are supposed to be in charge. That's why I'm wearing the crown. It's supposed to be me wearing the crown there. But actually, are we more ending up in a position where we are subservient to the AI, where we are acting as a liability sink for an artificially intelligent system? So, defining the term, a heat sink, you might be familiar with, sits on top of a processor or other piece of electrical equipment and absorbs the heat generated by it. And a liability sink is a person who absorbs the legal liability generated by the actions of an electronic device, in this case potentially an AI system. And often that ends up being the clinician who is at the end of a very long chain of decision making involving artificial intelligence. So with the Shared Care project, it was based around various different models of AI use in healthcare. And initially we needed to code the very traditional model, which is where the clinician and the patient work together, basing their decision on electronic and non-electronic data. The clinician is responsible for bringing in the patient's context, the patient's thoughts, ideas, concerns, expectations, and together they come to a final decision. There's always a lot of debate as to whether the final decision come out of the clinician or the patient. To be honest, I view it as coming from both of them together. It comes from the consultation, and it's joint decision making. And then in a clinical decision system with artificial intelligence, we're tending, unfortunately, towards a model that looks a little bit like this, where we have an AI system that is only capable of understanding electronic data. It is simply blind to data that can't be coded electronically. And the AI uses that electronic data, that limited view of the world, to come to a decision and spits it out. Now, the patient and the clinician are still trying to have their conversation, their consultation, but the clinician's abilities are now limited to either passing the AI's decision through to be the final decision, or potentially scrapping the AI system entirely, or scrapping the AI's involvement in the consultation and just reverting to the earlier model that I put up. And that's really the sort of key point of it, that single point of control that the clinician has over this AI-based consultation. And it's frustrating for both of the main two parties involved. The patient risks not being heard. They risk their ideas, concerns, and expectations don't feed into the AI's decision. Those things are elicited during a consultation rather than being immediately available electronically for the AI system to make use of. The patient can't really directly interrogate the AI and how things have worked there. And the consultation as a whole, we sort of tried to illustrate it with the diagram, it's shifted away from being a patient-centred consultation to having the AI sort of taking on this feeling of supremacy. And the clinician ends up feeling that they're not doing what they are best at, that sort of integrative ability where they're bringing in all the different sources of information and coming to a decision with the patient. They're simply just acting as a check on the machine, and they have to make a decision anyway because they have to decide whether they're going to pass the AI's decision on to the patient. And then the last bit is this question of liability. Well, as a clinician, should I just ignore all that and do what it says? Now, the AI systems are often rated in their performance against humans, but which humans and how much information does the human have that is being compared against? Like we said, the AI is blind to an awful lot of information that a human might be able to pick up on. But often in the trials of an AI system versus a human, they're actually put on a parity. They're given the same data set. Here's our question-answer pairs, and we're going to compare the performance of a human versus the performance of an AI. Well, as a human, I reject that. I'd go and see the patient, actually have a look at them myself. But that's not available in some of these studies. There's a risk of what we're calling algorithmic deference, which is a kind of defensive medicine where you might go along with an AI decision that you feel to be suboptimal, not dangerous, but not the optimal decision for that patient, simply because it's far more justifiable to go along with something that is documented in the notes as being supported by an artificial intelligence system. And there are some suggestions that AI might act as a colleague in some ways that you could sort of discharge some of your liability to by taking advice from the AI system. But when we've spoken to sort of legal experts, they've said that's a very, very dangerous position to put yourself in as a clinician. And it's against the guidance. The guidance is very, very clear. This is from various bits of NHS guidance that healthcare professionals should be making the final decision. I would say healthcare professionals and patients should make the final decision. And healthcare professionals may be held accountable for a decision even if the AI is actually the bit that's made it. So if we're not just going to blindly follow it, I love presenting just sort of completely false dichotomies, should we just ignore the AI? Well, this is from a paper where they compared 4 different scenarios. This was an AI system recommending ovarian cancer chemotherapy dosing. And the AI recommendation was either a standard treatment or a non-standard treatment. And the physician's decision was either to reject it or to accept it. And harm was assumed to have occurred. And they found themselves 2,000 potential jurors, i.e. normal people, and asked them, was the physician decision reasonable? And the answer, unfortunately, turns out to be that rejecting the AI's decision, even if the AI was making a non-standard decision, is always considered to be less reasonable. So simply by using an AI system and not just immediately deferring to it, you are potentially in a difficult place. So this is what I always say, the main risk to AI vendors is not the system underperforming or something like that. It's people refusing to engage with it, people simply just turning it off. But actually even that is potentially problematic because you can end up in a catch-22 situation that you could be considered liable as a healthcare system for not implementing AI systems that are shown to improve care. I think everybody in this room is probably fairly pro-AI. We would like to see the benefits of artificial intelligence. We would like to see it doing what we know it can do. So we've, for the shared care project, we studied the 6 different models of artificial intelligence system use in a consultation. We were using actor patients, real clinicians, and real clinical scenarios. Obviously, altered so they weren't exactly, but every clinical scenario was based on something that had really happened. And slightly worryingly, one of our clinical scenarios, after we had written it, then immediately happened in the hospital, showing how realistic it was. We tested 6 different models of AI use. First is the traditional model, the one where actually there's no AI present in the consultation whatsoever. And these are sort of outpatient consultations. One set were diabetes-based consultations around decisions of going onto insulin in a patient with type 2 diabetes who has poor or borderline control. And the other was obstetric decision-making based around whether you might go for a caesarean section, particularly, or a vaginal birth, particularly after a previous caesarean section. So the first was the traditional model, which doesn't use AI at all. Second, the model that I put up earlier, where the AI is making this recommendation based on data, and the clinician has to decide to either accept that or, after discussion with the patient, reject it and kind of go back to the first model. Third, a model where the AI highlights useful data but doesn't actually make a recommendation in itself. So it's simply throwing up to the clinician, here are things that you might want to consider. Here's stuff that I've pulled out of the patient's notes that might be useful to you in your decision making, but I'm not going to tell you what to do. Fourth is kind of a combination of the two, where it said, this is what I recommend to do, and here's all the information that I've pulled out to try and make these decisions. And this is going to sound a bit silly at the time, we thought the far future, where AI can actually talk to us, we might have a conversational AI, and people might want to use that in consultations. Now, clearly, we're quite pleased that we put those models in, because the future has caught up with us rather quicker than we originally anticipated. So, Model 5 was the efficiency model, where the AI and the patient have a conversation before the consultation and will come to a decision. And the clinician is now in the position where they have to rubber stamp that decision, or to have a consultation with the patient and go back to a traditional model. We tried to bring that in as being equivalent to the kind of Model 2. And I originally, it's had various names, this model. We called it the Stephen King model at one point because I thought it was so horrific. But actually, when I've spoken to non-clinicians, quite a lot of people did seem to think it might be a reasonable way to behave. And we've now sort of tried to call it the efficiency model. The idea is that the clinician can sit there, mostly rubber stamping AI decisions, but occasionally they act as that check, and they do bring the patient in and say, no, we do need to review a few things. And then the last one was the conversational AI based on quality. So the AI and the patient have a conversation before the consultation, but then the patient and the clinician have a second conversation. And the hope is that in that second conversation, the patient is much better informed. The clinician has had the opportunity to review that conversation and has got a much better idea of where the patient sits, and the AI has been able to elicit some of the information that might be useful. I'll hand over to Jo now, who will describe a little bit more about what we did.
Thanks, Tom. Hi, my name is Jo Iacovides. I'm a senior lecturer in computer science here at York, where I specialise in human-computer interaction. So in my bit of the talk, I'm going to be focusing on how we took those models and translated them into prototypes that we were going to use to actually test with clinicians, and there's more detail in the paper there that we presented earlier this year. So essentially, with this design phase, what we wanted to do was to take those 6 models that Tom just explained to you there, and to turn them into 6 different prototypes that we could then put in front of clinicians to use. We were inspired by the Wizard of Oz approach, which is essentially where the prototypes don't need to have fully functioning AI in order to be tested. We simulated the AI, we pretended it was a fully working system when we gave that to clinicians, but actually we'd already simulated responses for the clinicians to see. And what this does is it allows you to do some user testing and to gather some useful feedback from potential users before you need to go too far along in the development process. So we adopted a co-design approach here. So this was fundamental to the work we did in shared care, where we had HCI experts, so people who specialise in human-computer interaction, but also domain experts in safety and ethics and law, as well as psychology, and then clinicians. So we have that medical expertise too. So in order to develop these prototypes, it was really key to have that mix of people involved in the team in order to create interfaces that were usable, but also were going to potentially be useful to clinicians as well. And we should also say that we evaluated these prototypes before we put them in front of clinicians for our main evaluation. So we got some clinicians who were external to the project to actually have a go at using them, but also to look at the kind of feedback they were producing to make sure it was plausible within the different scenarios that we were planning to test. So within these 6 models, we had different versions of AI. So the first model didn't have any AI at all, so it was just the basic prototype that we gave to clinicians. But then in models 2 to 6, we had a plugin basically that clinicians could select, and that would give them different outputs depending on the underlying model there as well. So here is a screenshot of the prototype interface. So we were very keen here to make sure that the prototype looked like something that clinicians might use already. So we were looking at existing systems and keeping the design similar to that, so that people would be familiar with the kinds of information presented in it and not need too much hand-holding in terms of how to use the system itself. So we filled the system with patient data. As Tom explained, this was data that was realistic but not real data. And then for the AI bit, so here, once you click on a particular patient, you get more information relating to previous consultations, but also their medical history and any results and medication that they might be on as well. And in the corner there, you can see our shared care plugin. So this is where clinicians were encouraged to select this plugin in order to get an output from the AI. So I'm going to talk through 2 examples from those models, just in the interest of time here, but also these examples show you all the kind of core functionality of the different prototypes. So here we've got model 4, which is where the AI will produce a recommendation with information. So at the top of the output screen there, so that's what happens when the clinician presses on the plugin, they get a recommendation on the top. So in this case, the recommendation is to continue with changes to lifestyle factors and medication. And then you've got the additional information provided that is the basis for that recommendation. So this is essentially, model 4 is a combination of the previous 2 models, one that has recommendation only and one that has information only, and this one combines the 2 together. But the idea is that the clinician gets the outputs from the AI, but is also still consulting with the patient in order to make a final decision about that particular patient's care. In model 5, this is where we moved on to the chat-based models, essentially, or the chat-based prototypes. So here is, when we originally developed this model, we did develop it on the basis that we would actually not necessarily have an interaction between the clinician and the patient. So unlike model 6, where we do have that interaction, the idea here is this model would emphasize efficiency, and the patient would have a conversation with the AI before a decision is made, or as part of that decision making. So when the clinician looks at the patient's records, they still have access to all that information, but they also have, in this case, the recommendation plus the information. And at the end there, you can see that they can access a summary of the chat, but also the transcript of the chat itself. So they can review that conversation with the patient, and then they can make a decision based on rubber stamp the decision potentially. So here we were inspired by ChatGPT. When we developed the models initially, ChatGPT had not been introduced, but as the project progressed, we did use ChatGPT type tools to create a transcript around a conversation between the patient and clinician. And as I said, in model 5, the emphasis here was on the efficiency aspects, so the AI talking to the patient and making a decision before the doctor or the clinician then reviews it. Whereas in model 6, this was more about talking through the possible options and having a sort of pre-consultation before the main consultation with the clinician there. Okay, so I think that covers my main points. The idea, once we developed these prototypes, was then to evaluate them with clinicians, and I'm going to hand over to Vishal, who's going to explain more about that.
Right, good afternoon. So I'm going to talk a bit about the methods and also about the results as well from the study. So Tom's talked about the models and Joe talked about the interface, and our job was to kind of bring those 2 together and how we can actually test it with some clinicians. So we had our 3 diabetes scenarios and our 3 obstetric scenarios. And as part of those, as was already mentioned, we had patient history, reason for consultation, the next step in care, which we felt was appropriate for that individual, the AI's response for that next step in care, which may or may not align with clinical guidance, potential treatment outcomes, but we also captured patients' thoughts, feelings, and questions. Because we had actors playing patients, we wanted to make sure it felt realistic to the clinician, that the patients felt real. So we spoke to our PPIE panel, and they went through the scenarios, and they gave us lots of in-depth information about what sort of questions they would ask in that situation, what their thoughts would be, what their feelings would be in that situation, and we could then feed that to the actors to make sure the scenario was realistic as possible. And then we had these 6 models as well. So the plan was for each clinician, they would go through each of the 3 scenarios, so either the diabetes ones or the obstetric ones, and they would pair that up with one of the 6 models. So for example, you could have scenario 1 with model 3, scenario 2, model 5, scenario 3, model 2. And then the next clinician would be pseudo-randomized to a different pairing. So again, they would experience at least 3 models and all 3 scenarios, so that we could get a feel for their preferred model, the challenges they experience with each model, but also their kind of insights into what works well for them and from a clinical standpoint. So in our situation, we had a clinician and the patient actor going through the scenario one by one. And we took that data, we transcribed the conversation after recording it, and that transcription was fed to a Bolam tester. This was an independent clinician that reviewed the transcript to verify did the consultation go as what would be classed as good practice, were there any challenges or barriers that they felt popped up in the conversation, and did they feel the AI integration was a useful addition to the consultation. And as part of the data collection, we had post-scenario and post-session interviews with the clinician. The actor patient completed a post-scenario survey, and the Bolam tester also completed a post-scenario survey as well. So all this data in unison was then analysed to understand the actual impact of having an AI in the consultation, but also understanding what model of AI was preferred by patients and by clinicians, but also the actual clinical implications of that going forward. I'm now going to talk about some of the results. So we had 21 clinicians, 13 patient actors, and 27 Bolam testers. Now some of the results from the patient actors are on your slides there. In terms of being made aware there was an AI present, as you can see, most of the time the clinicians did not tell the patient there was an AI available in the room that was being used. And even in model 6, where the patient had already interacted with the AI separately outside of consultation, clinicians still did not mention there's still an AI there giving information and guidance to determine what would be the next course of action. And obviously models 1 and models 5, there was no AI, and on model 5 the patient was not seen by the clinician. And we also asked the patient actors if they came to harm based on the decisions made in that consultation, who would they hold responsible? And overwhelmingly, the doctor was considered to be responsible if anything went wrong. Very few would consider themselves to be responsible, and even a small percentage thought the AI was responsible. Now this aligns with some of the feedback we've got from our PPIE panel, who stated that it's the doctor's job, that's their job to keep us safe and provide care, and the AI is just a tool that's available to them to use. So this actually aligns quite nicely with that, and also with the views of our clinicians as well. Now in terms of the clinicians' data we captured from the interviews, we did some thematic analysis, and I'm going to talk about some of those results now. So there were 3 themes. The first one was in AI we trust. Now this focused on the actual models being used and the data being provided. So the first sub-theme was comfortability with the scenario. And what we found was in the situation where the scenario was familiar to the clinician, they had lots of experience with, they were quite happy or more comfortable going against the AI if they felt it was incorrect or inaccurate. But at times, when it was a different scenario that had less experience of, they felt quite uncomfortable and they felt a bit more uncertain about what the AI was saying, especially if the AI felt like it was missing something or was oversimplifying the scenario itself. So one of the scenarios in the obstetrics ones, the patient had a previous vertical cesarean, so classical cesarean, and the AI output kind of missed that and said, oh, it's just cesarean, so you can do X, Y, and Z. but its recommendation was actually contraindication to having a classical cesarean. Now, some clinicians felt like, actually, the AI's missed this, but do I go against it or not? I'm not too familiar with this situation, what do I do? So there's that nervousness there. The second bit was around the data itself that was being presented. In some situations, the risk being provided was quite reassuring to the clinician, because it was data they were comfortable with and familiar with, and the numbers aligned with what they were used to. In fact, one clinician even mentioned, I can't keep all the numbers in my head all the time, so having this here as a little sense check is actually quite useful, because they seem familiar and seem realistic. But at the same time, clinicians were a little bit nervous about where the numbers came from. Was it from national guidance? Was it from trust guidance? Was it from a research paper somewhere? They wanted to have that verification of the numbers themselves, and also wanted clarity, were the numbers generic to all patients in that situation, or was it for this individual sat in front of me right now? The next themes focused on the risk of depersonalizing medicine. The first sub-theme focused on the fear of clinical over-reliance. And we touched upon this a little bit more this morning as well, where there's that fear of what actually happens when the clinician using this AI becomes over-reliant. They might not be as experienced, and they're actually doing something that might cause the patient harm. Quite a few of the clinicians mentioned that as a senior clinician, they have a sixth sense of what's the right thing to do in a certain situation with a certain patient in front of them. But if you have more junior doctors who haven't had that experience and haven't developed that sixth sense, is there a risk they will go along with what's being mentioned by the AI and potentially put the patient at harm? And the second part as well was the de-emphasizing of human touch. A lot of clinicians, mainly in Model 6, found that the conversation the AI was having before the consultation actually had an impact on the consultation themselves, because that conversation of understanding the patient's concerns, the questions they had and their risks, was a way of building that rapport to understand the patient and then make that decision. But since the AI was doing that for them, they kind of felt like, well, actually, what's my job now? And a lot of clinicians then actually went back and went over that conversation again to then build that rapport, build some confidence and trust, and then make that decision. So actually, it wasn't actually saving much time for them, and actually made them a little bit more nervous about, I need to build more rapport and actually try harder to build that connection before making a decision. The third theme focused on the impact on clinical decision making. And as has been actually mentioned today already, clinicians were taking on responsibility if something went wrong. They all agreed that it was their responsibility. If something went wrong, it was my decision to make. And that's why in situations where the AI would say, recommendation is X, clinicians did not like that unanimously. They all hated being told what to do because they felt it was their job to make that decision. And that goes along with the second sub-theme of algorithmic deference. And as Tom mentioned, there are times when clinicians felt a little bit of pressure to go along with what the AI was saying because they were thinking, have I missed something? Has the AI missed something? Who's the responsible here? And is it my job to agree or disagree with the AI? And that led to a lot of uncertainty and anxiety among the clinicians about what they should be doing and should not be doing. In general, the view was that AI can provide a useful second opinion if it provides them with extra information and guidance of what to think about, but clinicians felt very, very strongly that AI should not be making that decision for them. So a quick summary. It has the potential to be a decision support tool. It should not be making the decision, and clinicians always, always, always wanted to speak to the patient. So in Model 5, when they were given that option of the conversation has happened between the patient and the AI, here's the decision, just tick on yes, they all said, no, I want to speak to the patient as well. Even if the decision wasn't in agreement with what they were thinking, they still wanted that reassurance and having that conversation with the actual individual patient. So in terms of AI in healthcare, results suggest it can be beneficial. It can have a positive impact if it's done in the right way. Now, one of our PPIE members mentioned that our trust has always been in people. So from their point of view, having an AI make a decision and having an AI being involved in that consultation process was a little bit nerve-wracking and a bit scary. And from a clinician point of view as well, their view was, actually, I'm responsible here. I want to have that conversation. I want to make that decision with the patient there in front of me. So there are potential for AI in healthcare, but it's got to be done in the right way and actually involving clinicians and patients from the outset. Patients in particular, they are new to AI. They don't understand AI, the impact of it, and they need a lot more reassurance to bring them on board in that journey to make sure they can get the best out of it as well. Thank you all.